Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for a successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Thank you for joining us for Conversations in Hematology Oncology. During this segment, we'll be discussing case studies to illustrate best practices. I'm Matthew Lunning, Associate Professor from the University of Nebraska Medical Center, and I'm joined today by my friend and colleague, Dr. Gilles Salles, Chief of Lymphoma Service at Memorial Sloan Kettering Cancer Center in New York. You know, I can think of the last 5 follicular lymphoma, new patient visits, and they're all different, Gilles. It's just mind-blowing these days of how just diverse, follicular lymphoma is, from your active surveillance patients to those who have low burden disease and, but still can't get to bed at night knowing that they have lymphoma. Those who have disease that you would think about treating and they're like, I'm asymptomatic, I don't want to be treated. And those who come screaming in there and you biopsy them and you're like, golly gee, this smells like large cell lymphoma, but the biopsy, despite an excision, continues to be follicular lymphoma. I'm just impressed by the diversity of this disease and how it can, really kind of, you're walking in the door thinking it's going to give you one presentation and then you get another.
Well, I think what you say is very important. We do see patients which have very different needs, and we need really to sit with the patient to discuss, to evaluate the patient, to evaluate how they live, what are their expectations, what do they want to do, and discuss that. We also have to evaluate the disease. And right now, PET-CT is a major tool to see what are the patients, obviously, who have a large tumor burden, but also those with a high SUV that smell something that may not be appropriate without chemo. So when we discuss with the patients that are reluctant to have any chemo, bendamustine or CHOP with rituximab or eventually obinutuzumab, we are then with patients with a chemo-free option. So what is available now is rituximab single agent, or if you get approved by your insurance, and that may be depending on the place, R-square, it's in the NCCN guideline as a high level. So I think I haven't had difficulty of getting it approved, and I like it, but that's on the table. So, rituximab single agent, I will say, when patients are really in need of therapy, I rarely use it. I use it sometimes for patients who are, kind of borderline. They don't meet Gulf criteria, but they have disease which is disseminated, not suitable for localized radiation therapy. And, the watch and wait is not necessarily appropriate. They would like to do something. And maybe, there are some patients really, the results are well known. 3/4 of these patients respond to therapy, and about half of them reach a CR, and the CR can reach several years. So I don't throw that away. It's not my practice usually. If they have a low tumor burden, I usually don't treat them. But there are a few patients that, even with a higher tumor burden, and when I arrived here, I saw patients that was treated 15 years ago with rituximab single agent, a large tumor burden. I will not have offered that to this patient, and he's still in CR. So those patients exist. So my favorite chemo-free treatment options right now is R-square. So R-square, we have the relevance data showing that it's equivalent to immunochemotherapy, our CHOP or our bendamustine, in terms of response rate, in terms of duration of response. And, we learned last year that the 6 years PFS is identical for those regimens. So it's an approved regimen. It's not necessarily as easy to manipulate that rituximab single agent. You have the rashes, and the rashes occur in about 10 to 20% of the patient. Most cases, you withdraw land for a few days, you give steroids, you give antihistaminics, you resume. But in some patients, it's quite severe variation. You have to discuss with derm people, eventually use these antibodies against these rashes. And, it's not necessarily a home run for some patients. But I have found that quite useful. The second thing is that you have to still take care of the risk of thrombosis. And, whether you put your patient on aspirin or something else, If they have a large tumor burden, there may be a concern of compression. So keep that in mind. And finally, we have older patients, and you have to think about the renal function. We have to think about the little neurological effect of lenalidomide. Some patients are a little bit confused, not confused, but don't have the perfect 100% meaningless. So I think it's a good option. It's my preferred option. It's my recommendation for patients. But I think we look for something, and I was quite intrigued and interested by the result we presented at ASH with mosunetuzumab single agent. And I think the Celestimo trial and the other trial that we look at either mosunetuzumab alone, mosunetuzumab plus len, or the anti-CD20 will probably bring other ways to manage patients in the first-line setting.
So I find R-squared a very interesting regimen, not only in the front line, for follicular lymphoma, but also in the relapse refractory setting. In my experience, not many patients end up on the same dose of lenalidomide that they started with at cycle 1. And I think that there's often a right dose, and then there's the right dose for the patient. And you figure it out by about cycle 3 or 4, what is the right dose of lenalidomide. And I can't state, more eloquently than you did, pay attention to the creatinine clearance, right? Because we have seen both in the AUGMENT trial, that you can put patients who have a creatinine clearance between 30 and 60, on 10 milligrams of lenalidomide. They have good efficacy, good durability, and I even look at if they've been hovering around that creatinine clearance of like 50, and then sometimes they're 65. I will start them on a lower dose of lenalidomide just in anticipation, that they're going to spend more time, with some mild CKD and still, drive benefit from the lenalidomide, whereas I probably would get to that lower dose eventually.
Yeah,
very much a finesse drug.
Yeah, I agree with you. I mean, I have also, these little cramps. If you have patients in particular professions, like musicians, I have a patient that had to adapt that, a few things like that. But, we all know that first-line treatment is good. And in some patients, you reach a couple of years of treatment-free interval. But unfortunately, patients relapse. And I would like to ask your opinion about the feature of the relapse patient. We discussed the POD24, but in general, what are you aiming for patients? Is that age dependent? Is that tumor volume dependent? Is that treatment-free interval? How do you categorize the patient for the second or even the third-line treatment?
Yeah, no, I think after their first line, I'm really looking at, one, we haven't talked a lot about maintenance. I think maintenance in follicular lymphoma kind of went away with COVID a little bit. In my practice, I wasn't willing to accept that risk. And so I haven't really brought it a lot back. But if you're relapsing on maintenance rituximab, I think that's a different patient if you are choosing to give maintenance from that standpoint. I also try and stay a little bit tried and true to the POD24, meaning that it was a patient, required therapy within 6 months of their diagnosis. I know in the POD24 data, they got CVP or CHOP or R-CHOP, but still in BR, I think that matters. And so in my practice, if you had a symptomatic progression within 1 year, if not even 2 years of completion of their therapy, that's a big deal for me. That's a prognosis changing event. I also use the CIBMTR data to look at if I can't prove transformation in that relapse. I'm not sure that the conversation about auto transplant is completely dead in follicular lymphoma. I think there is a sliver of that. So yes, if you're young and you have no comorbidities and you have an early relapsing follicular lymphoma, I know we have R-squared. I know we have CAR T. I know we have bispecifics, but I think that there's long data that shows plateaus on those curves and very similar population. And you have the CIBMTR data again of those patients who got there. But an early relapser, I may consider CAR T cell after R-squared. Sometimes people don't have access to lenalidomide too.
Yeah, I think I agree. I mean, I used to have a lot of patients with transplant, but I think right now I really reserve this indication for patients with transformed disease and discuss transplant or CAR T. That's another discussion. Having said that, I think that, right now, if you have started with chemo, trying R-square and designing for intensification after evaluating the response to R-square is really my preferred way, even for young patient, even patient with bulk, as long as they don't transform. Obviously, biopsy and rebiopsying this patient and watching them carefully is key. And if you started with R-square, I think, there was some data from Houston, I think last year or 2 years ago, suggesting that if you have failed an immunological treatment, you better get chemo the next time before to go to something else. And that's what I recommend to patients, because you are worried when you don't get that. So I think right now, you get into third line. And for me, third line, then we have CAR-T approved. So if I really want to treat this patient, I will probably prefer to treat him or her with CAR-T, reaching this high response rate, not have it to debulk too much, rather than with auto transplant. We also know that, auto transplants, they have this long-term, side effects, the risk of MDS, the cardiac toxicity, a few things like that. There was a recent papers. So, I don't think we experience that with CAR-T, or we don't feel that. Maybe we don't have enough follow-up. So I have really displaced that, except in a very minority of patients. Did you do any allo transplant for young patients recently?
I have not done an allo transplant in follicular lymphoma for a very long time. Number of years. I think we just have that many options, now for follicular lymphoma, where we can kind of line by line. But I think you do cross that, in those 40, 50-year-old follicular lymphoma patients. What is that line where you're like, if I get you a CR to this, then we're going to go. And I think it's, it's not after bispecific and it's not after CAR. It's likely after bispecific and after CAR, but then you're doing something. If you're refractory to both of those lines of therapy, you're likely going back to the chemo tree, right? If they hadn't transformed, a lot of patients will have gotten BR, R squared, bispecific, CAR-T, and then, you're probably giving them an anthracycline and having the discussion about consolidating after anthracycline. I mean, I was joking back when we were having the SWOG 1806 study, which was for those POD 24 patients. We were going to learn for the first time in second line follicular lymphoma what the overall response rate and CR rate was to R-CHOP, right? We had never, I couldn't find a single paper. We were going to learn something. Unfortunately, that trial is not accruing the best, but maybe we'll get some data to show what a CR rate is in the second line.
Yes, I think we recently published the Sloan trial, which was R-CHOP or R-Benda combined with ibrutinib. Ibrutinib didn't help to these patients, but you have now in this randomized trial where the majority of patients have had R-CHOP before, and this was mostly BR second line rather than the opposite, but at least you have this data somewhere. What about the elderly patients that do not tolerate very well chemo, doesn't want chemo, or even the young patient that doesn't want to hear about that? When you come to second, third line, how do you manipulate that? Do you think that we can sequence R-square bispecific, go one back to one other? How do you figure that out?
Yeah, I think with mosunetuzumab in the mix, here, I think it's moving up in our armamentarium. I don't think it's going to sit in the third line setting. But it appears to be a very well tolerated regimen. I think that it spans, that young, fit, all the way to, frail and advanced age individual as an agent that can get in and treat follicular lymphoma. I like that it is, fixed duration therapy. I think that that's something that will be appealing to those individuals that are choosing it in follicular lymphoma. With regards to, if we see other bispecifics there, if epcoritamab gets a label, I think it's going to be interesting to try and sort out, that's a continuous therapy. Yes, it is sub-Q, but when do you use Mosun and when would you use EPCO? And I don't have a good, feel for that quite yet, other than, maybe EPCO, because it has activity in large cell lymphoma. If I feel that the gears, that follicular lymphoma is marching towards transformation, maybe I'll try EPCO in that situation. Or if you just have a person who's blowing through first and second line therapy, if EPCO gets a label, that might be. But right now, I think Mosun, as we get more experience, kind of dominates that third line space.
Yeah, what I like with Mosun in this setting also is the fact that, you have the first cycle with, the step-up dosing. patients are coming weekly, and after that, they come every 3 weeks. So, you go back to a schedule which is not very cumbersome. So I think patients like it because of that. And even if they have a little bit of side effect at day 8 or day 15, and we discuss that, we manage them. But then after you get to something that is a usual schema, so I found some patients with fatigue on bispecifics, but they usually recover. What happens to those patients that you have encountered who have failed CAR T cell therapy? If they have not received bispecific, I imagine it's easy. What happens if they have received both? Will you try those? You will try to enroll them in a clinical trial, but do you have any insight of what we do? Do you think it's as bad as failing CAR T in the large cell setting, or do you think there is still a lot of possibilities for these patients?
Yeah, I think that's where, these novel agents, I think tazemetostat, there's probably very little data of tazemetostat post-CAR, post-bispecific. I can't imagine there is outside of the, a handful of patients. I think the other, class that's going to kind of infiltrate here is going to be BTK inhibitors, namely zanubrutinib. I think a lot of people are going to be obinutuzumab naive too. I don't think there was a large adaptation of the gallium data. I think if you're getting bendamustine, you're getting a lot of rituximab. And then you're also, if you relapse, you get R squared. And then you're pretty much, so Obin, maybe there, and Obin Zanu, I know we're talking like 5th line follicular lymphoma, but we're also talking about how to get, 50-year-olds right now to 75. Or 60-year-olds to 85 in follicular lymphoma, and trying to, not give something that presses that clone to large cell lymphoma. And that's, I think, where the prognosis changes.
Maybe before I hand up to you to conclude this session, maybe 2 anecdotes. The first one is a patient that received CAR T probably 2 or 3 years ago with follicular lymphoma and relapsed. And I continue to monitor this patient. He has a limited disease, 2.5 centimeters, 3 centimeters. So I manage it like the other follicular lymphoma. So it's not because it's a post-CAR T relapse. As long as there is no transformation, this patient doesn't need therapy, has understood that, is a young patient we'll see in the sun. The second anecdote, and I think we all have seen that, are these patients that have been receiving multiple treatments, and suddenly you don't know not much what you do. You do a little bit of chemo, a little bit of R square, or even rituximab single agent. And you find this patient responding and alive a couple of years later. So, never lose hope for follicular lymphoma patients. As long as they don't transform, there is always the options of trying to repeat the anti-CD20 alone or in combination. And I have seen several patients, the longer treatment-free interval is the last one, and it can be the 5th one or the 6th one. So never leave or lose your arms and continue to accompany this patient on their journey.
I can't agree. We started off kind of this segment talking about just the diversity of follicular lymphoma as it presents, and the diversity of follicular lymphoma, even when it's in the 4th, 5th, 10th line plus therapy. Well, with that, thank you again for joining us for this segment on case studies to illustrate best practice approaches. Please be sure to click on the landing page for this activity to claim your AMA, ANCC, ACP credit, access supplemental slides, as well as other topic segments and case scenarios.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.